Well, the open session of the Board of Directors meeting is now open, and I'd like to have report from our legal counsel on action taken in closed session.
Certainly. So the board considered 5 items tonight in closed session. The first was a report involving trade secrets pursuant to Health and Safety Code 32106. There was no reportable action. Second, they considered approval of closed session minutes. The minutes were approved on a 4-0 vote. 1 member was absent. Third, they considered a report involving trade secrets under Health and Safety Code Section 32106. No reportable action. Fourth, there was a hearing conducted under Health and Safety Code Section 32155. The medical staff credentials were approved on a vote of 4-0, 1 member being absent. And lastly, there was a hearing under Health and Safety Code Section 32155 with no reportable action.
Thank you so much for that. Are there any deletions or corrections to the posted agenda? Hearing none, we'll move on to item 10, and this is audience input, and this is an opportunity for the public to speak, and they have 3 minutes to address the board on whatever their topic is. And it's known that it's not on the agenda, then we can't discuss it, but we certainly can acknowledge your presentation. So do I have anybody from the public that would like to speak? Could you come to our lectern and give your name for the record?
Stand up. Hey, it's official. Is
Is
this
it on?
recorded? Yeah. I can listen to it later? Yes. Awesome. Thank you, first and foremost, for the opportunity to speak today. My name is Dr. Jeffrey Fountain, and I am the current medical director of diagnostic imaging here at Tahoe Forest. I am here today to discuss with you a few issues associated with diagnostic imaging, and hopefully in discussing those can obtain your support. First of all, I'd like to talk about volumes. I think that's one of the big issues that we've been experiencing, and one I think that most of us already know, but I would like to discuss that in just brief detail. So obviously the health system has gone through some rapid change. We're growing tremendously with providers and seeing patient visits. Harry announces that on a pretty regular basis, and obviously those end in additional imaging and exams. We have seen a rapid, unprecedented increase over the last probably 6 years. In fact, I think the recent statistics we just saw last week was that we are 27% increase in just the last 2 years between the beginning of 2021 to the end of 2023. I mean, that's unbelievable, 27%. I mean, most people plan for about 5 and hope for 7. Now, obviously, we've had to do that with the same staff. We're currently still staffed at 4 FTEs, 4 full-time radiologists, and for the most part, we've been able to handle that. However, this last couple of years with this huge increase, we have seen and experienced some struggles. And one of the reasons for that is that we hold ourselves to such a high standard. It is our expectation that we try to provide the best patient interaction, fastest turnaround time and efficiency, and the highest quality imaging that we can. But there's obviously a breaking point, and we're getting very close to that. One of the things that makes this particular discussion difficult is the type of volume, the unprecedented and the unpredicted volume that we have. Obviously, we are a big ski community, and a lot of our patients come into us unplanned. They don't show up hoping to come in, right? And so we can't plan for that. It's very difficult for us to prepare to have so many docs on staff or in-house to make sure that we can handle the patients at that high volume. So one of the things that we tried to do, and this conversation started about a year ago, and something that we refer to as jeopardy. So we typically staff the department with 2 full-time radiologists, and we can, like I said, majority of the time handle that volume. However, when we started having this discussion of jeopardy, which was almost exactly 1 year ago, we sat down with some of the administrative team, Scott Baker, Louis Ward, Dr. Brian Evans, and we tried to compromise, right? Try to find a way where we could set a quality ceiling or a quality limit, but still be able to obviously be financially sustainable. We set that standard, and we followed the protocols, right? We jumped through the hoops, we went through compliance, we followed the list. We were able to initiate that program at the end of November of this year. And I've got to be honest, it was very well received. We were able to cover our trauma department, cover our emergency department, cover our orthopedic team, and do that on an ad-needed basis, which was really the key, right? 3 o'clock today is a good example. I at 3:30 hit 80 RVUs, and at that point in time, I wasn't very productive. We had a bunch of ski trauma coming in, and I couldn't keep up. So we had to make some adjustments to that schedule to make sure that we could still provide high-quality care. And this has been happening very frequently. In fact, to start this year off, we have had, once again, estimated levels of volume that will probably oversee or be even greater than we had last year. Either way, unfortunately, after we initiated this Jeopardy protocol, it was abruptly terminated 2 weeks ago. And the only explanation that we received was because it didn't meet compliance. And I am not a compliance expert, and so I can't speak to that. But what I can speak to is what it provided to our medical staff, our patients, and our health system. And hopefully in that description of what I was able to tell you today, you can see the benefit. It was very helpful. It was able to cover our departments better, provide better turnaround times, higher efficiency care, and just an overall benefit. The second topic that I'd like to speak to today, because I know my 3 minutes is just about up, is there's been suggestion that we handle this volume with teleradiology. And just in quick summary, we are adamantly against that. Let's be honest, we're a team, medical staff, and we work together every day. I see these folks in the cafeteria.
And while you're in the cafeteria, I'm going to have to call your 3 minutes.
Oh, okay. Either way, please support us in no teleradiology.
Yeah, we appreciate what your presentation has been on.
Thank you.
Is there another audience input?
Can you hear me?
Yes.
Yep.
Yes? Okay, good. Good evening. Good to see you all again. For the record, my name is Deirdre Henderson. I live in Truckee. I'm a patient here at Tahoe Forest, and I head the North Tahoe chapter of Citizens Climate Lobby and 100% Renewable Truckee. When we were preparing for this meeting, we took a look at your agenda, hoping that we would see something about the Mazzetti contract and progress on that. We didn't see anything, so we then looked at the agenda packet, and finally, on page 211 of the agenda packet, we found a short report from your COO, Louis Ward, about the Mazzetti contract. So thank you, Louis, for putting it in there. But we'd like to suggest that the step that you've taken is a really important one, and one that you ought to hear about frequently, and we ought to hear about frequently. So I'd like to suggest that you make it an agendized item for your meetings, that you always have a sustainability report. I'm going to take a little diversion here, but I promise I will connect the dots for you. When I drive back from Reno to my house in Truckee, I see 2 billboards from Tahoe Forest. Parenthetically, I'm not really proud that Tahoe Forest blights our landscape with billboards, but be that as it may. One of the billboards says that Tahoe Forest has a level 3 trauma center. I think I might be maybe one of 3 civilians in this town who knows something about what a level 3 trauma center is, and that's only because my son is an emergency medicine doctor, and I asked him. However, most people in this town do know something about climate change because we're experiencing it. I think are very concerned about sustainability. And therefore, I think that if you had an agendized item, the community would really appreciate hearing about what you're doing, particularly since you've taken this very important first step. I have one other thing to mention to you, which I've mentioned before. I've mentioned that Healthcare Without Harm and Practice Green Health runs a Clean Med conference. It is the most important conference for medical centers around the country on sustainability, climate change, and equity matters. And it's going to be in Salt Lake City at the end of May. I've mentioned it previously. I've given you a list of those who have so far said that they're going to be attending. You'll see that the American Hospital Association is listed, the Association of American Medical Colleges, many health centers, many insurance companies. It would be great if you could find a way to send someone to this conference. It's a great way to learn and to share. Thank you.
Thank you. And again, you've asked about our report from Mazzetti, and I think when we have it together and what our plan of action is, we will hear it, and the community will hear it as well. We're not ready to do that yet.
Right. I was simply saying that as a general matter, it would be nice for there to be an agendized item because this is so important.
And there will. Thank you. Any other input from the audience?
Good evening. I'm Tennille Bainey. I'm the medical director and chair of the Department of Anesthesiology. And I kind of want to pick up where Dr. Fountain left off and just talk about the virtual radiology topic a little bit more. We did discuss this at our medical executive committee meeting last Thursday, and perhaps Dr. Koch has already shared this with you, but I just wanted to make sure that you guys were all aware that there was a very strong unanimous opinion from all the medical staff leaders at that meeting that this change of moving to more virtual as opposed to in-person radiologists would result in a significant decrease in the quality of care we are able to provide patients. This is related to, as Dr. Fountain mentioned, increased turnaround times, lower quality reads, and lack of access to our radiologists for collaboration. You know, our medical staff is unique in that we are amazing, and we're a special rural health system in that we've attracted this robust, smart, engaged, extremely well-educated medical staff. And because of that, we are living in this community. We're accountable to each other. We're accountable to our colleagues here at the hospital, to our patients that we take care of here, that we also see in the community when we're on the trails or at the grocery store. And that is what really generates great quality of care. And when you move to a more virtual model, that goes away and you don't have that. And we all, as employed physicians of this health system, are acutely interested in the long-term viability of our health system. And we appreciate that this appears to be a cost-saving measure right now for our institution. But I would just encourage the board and everyone who's reviewing this potential option to consider the long-term impacts of that and our potential loss in market share and patients that go to other facilities that are pretty easily accessible in Carson City and Reno. If our quality goes down and our turnaround times increase significantly. Additionally, the physician satisfaction of all of the other physicians that work regularly with radiology would decrease significantly because we value their accessibility so much and their fast turnaround times and being able to sit down with them at a computer and review reads and go over things. So I just wanted to make sure that everybody was aware that all the physicians that were at that meeting and all the physicians and surgeons that I've spoken with about this topic strongly support expanding our in-house radiology department with physicians that are directly employed by Tahoe Forest as opposed to moving to a more virtual model.
Well, thank you so much, Dr. Bainey. And the board has heard it. We heard it from Dr. Koch, and we know where you guys stand on this. Any other audience input? Okay. If none, then I want to move on to input from our Employees Association. We always give them an opportunity to say something, but no one's here, so I'll go ahead and move on to our Medical Staff Executive Committee Consent Agenda, and that's Dr. Koch.
All right, so last month we brought to you the annual plan approvals, but we didn't quite have everything together that we needed, and we do have that together now. And so I know you've received the packet that goes through all of the plan changes, or that goes through all of the plans, and I have a little summary of the changes that I'd like to just review with you. Does that sound like a good way to start here?
Okay, are they, for all of the changes that
This
you
is
have-
just the changes
Okay.
that were made, right. So the QAPI plan, the Quality Assessment and Performance Improvement Plan, they were just minor revisions, specifically the mission, vision, and values and winning aspirations were changed to reflect the new changes here. The priorities were updated to reflect the Vizient project and the plans for an enterprise-wide data governance strategy. They added the multidisciplinary patient experience committee. They updated the QAC annual plan approvals list by adding the policy numbers. They revised the NQF endorsed set of safe practices to the critical access hospital NPSGs. And then there were some minor wording changes. The utilization review plans had no changes. The risk management and patient safety had some minor changes, including the risk management plan and safety plan were merged into one policy. The risk statement was updated. And the hospital now endorses the National Patient Safety Goals for Critical Access Hospitals program. They previously endorsed a different program called Safe Practices for Better Healthcare. They also updated the safety priorities for 2024 and updated the references. In the discharge planning annual plan, there were minor revisions. They basically updated the risk statement, and that's it. Infection control, no revisions. The emergency operations plan updated the new clinic locations and then updated the community partners and contact information. There were no other revisions until you get down to the policies with the changes that actually need approvals. Available critical access services, the minor revisions were the IVCH updates related to rehab services and mammography, and then the IVCH updates related to telehealth services, including hospitalists for telemedicine services. And then finally, new policy approvals were the management of disruptive behavior.
Okay.
So do you have any questions on any of those?
I'm glad to see all the risk statements are there.
I'll thank others for that.
The only other thing I'd like to ask that had happened is that once we approve these, then the policies are approved. Someone will push the button to say, accept changes. My concern is that someone needs to look at all of them to make sure when the changes were accepted, the format was kept and all the new additions were there. Because as I was going through them, it's really kind of wonky, the way it's set up with the track changes, especially safety and risk and safety. That had a lot of deletions and renumberings. And it's only a.
You don't want to see the track changes?
Well, no, I'm not saying that.
okay.
No, I'm saying that when someone pushes the button to accept all the track changes on
Oh, that the formatting remains.
that everything remains the same. Otherwise, it's not going to be correct.
So maybe each person who provided us with their plan update can do the review for
Yeah,
them.
so like tomorrow, I go and I send an email out to all the managers and directors to update these policies, but I'll make sure that that recommendation is in there as well. Oh, sorry. Do you want me to come up there?
Yeah, real quick. Just repeat it then.
Okay. Is it on?
Yes,
Yeah.
should be on.
Hi, I'm Dorothy Piper, Medical Staff Director. So as of tomorrow, I will email all of the directors and managers with the revised changes and the approvals, and then also advise them to ensure that when the track changes are accepted, that they review the formatting to ensure that it's in the correct policy format. Is that, any questions from the board?
Anything else from the board regarding any of the plans? Anything from our staff? Our audience have any comments about? Okay. Then can I have a motion to accept the Medical Staff Executive Committee calendar.
I move to approve the Medical Executive Committee consent agenda as presented.
I'll second the motion.
Can I have a second, please?
Second.
Okay, so it's been moved by Director Barnett, seconded by Director Brown to accept the Medical Executive Committee meeting consent agenda as presented. All in favor?
Aye.
All opposed? Then the consent agenda has been approved. So thank you so much, Dr. Koch.
Thank you.
It's a lot of plans to have gone over.
Yeah.
Okay, number 13 is our consent calendar, and these are usually routine reports by our staff or our directors. But the board has the opportunity, if they wish, to pull any of them for further discussion. Are there any items that anybody wants to pull?
No.
Does our staff have any of the items that they want to pull? No. Does our audience have any comments on any of the items on the consent agenda? Okay, if not, can I have a motion to approve the consent calendar as written?
I will vote for approval.
Yes.
I'll second that one too.
Yeah. Okay. Are you going to,
No, I'm not going to pull that.
okay. So are you going to, were you the motion to approve?
Yes, motion to approve.
And you were a second?
Yeah.
Okay. So it's been moved by Director Shamlin and second by Director Brown to accept the consent calendar as presented. All in favor?
Aye.
Aye.
All opposed? Then the consent calendar has been approved. Our next item, 14, and these are for discussion. We have Dr. Koch, who's going to do an update on the dyad leadership structure. So it's all yours.
Excellent. So this is Dr. Koch providing the update on the dyad leadership structure. And there's not a lot to update, but I wanted to just share that there seems to be a significant synergism going on in a couple of departments, especially urgent care and pediatrics, where the leadership, the clinical leadership and the operational leadership are really getting together, really creating a solid foundation, a solid chain of command, and the morale is clearly changing in those departments for the better. There are snags in some of the other departments. And, you know, for example, the primary care department is just so large and the different locations have different needs. It's a much more difficult challenge. But at least we're seeing some areas where the dyadic leadership model is starting to pay off. So I just wanted to share that.
Thank you for
Thank
that.
you.
Yeah.
It's good to
Yeah.
hear.
Do you have any questions for Dr. Koch on the dyad?
So do you think it's a matter of time in the other departments, or?
There are growing pains. I think that there are some people who are not currently well seated to their roles, but that may be able to be trainable into their roles, you know, be educated up into those roles. And there may need to be some division of labor in different ways. Yeah.
Okay. Anything else? Anything from our audience?
Orthopedics, I can speak to as an employee.
Do you want to come up to the microphone,
Sure.
please?
Hi, I'm Dan Cole, and I'm one of the physician assistants from the orthopedics department. I would say that there's a very good dyad model in Dr. Dodd and Director Olson's performance of their duties, and that's reflected in our clinic's high performance scores, high patient volumes, and also our extremely high patient satisfaction scores. And that's been in place since Stacy Olson took that position when we integrated the practice, and Dr. Dodd and Director Olson are a fantastic team. I can speak to that as an employee and also as a provider. So I would like that department known as well as one of those demonstrated departments. Thank you.
All right, thank you. Well, that's really good to hear about how the dyad's working, and that there are models now within our own organization that other departments can look at and find out how it happened and how they can replicate it. So thank you again for that. Our next point is 14.2, and this is Jenny Parvin, who's going to talk to us about an update on our district high reliability certification. And we've got our Chief Human Resource Officer with her.
Hi.
Hi.
Hello.
All right. So we're going to talk to you about our journey to high reliability. And we put together a small presentation, which is just going to kind of keep some of my comments organized. So I wanted to do a brief overview. I know you all kind of know our history with this, but in brief, we started this journey in 2014 with Just Culture. And I'll quote Just Culture because we worked with an organization that's their term, is Just Culture. And soon after that, we actually left that organization and went with a different consultant because we believed in the methodology that the new consultant brought. And that was to look at systems and judge systems before we can judge the person. And we felt that was really important to the culture we were trying to bring to Tahoe Forest. Now, since that time, in 2014-15, lots of changes have come out related to Just Culture and then high reliability. We eventually went to a model where we called it collaborative culture of safety, and now we're getting to a much more structured approach with an organization called the DNV, which I'll talk about soon, where they're really terming it high reliability and Just Culture as one. So I'll keep going, and feel free to interrupt me, Jenny, if there's anything going on. Just a quick slide. I'm not going to read through this, but high reliability and Just Culture are crucial in healthcare, right? We know this. It's really important to make sure that we have great outcomes and that we're treating people right and that we're making sure that we approach events in an appropriate fashion. That's really what I want to get out here. Is the other thing I do want to mention here is that because we've been on this journey for 10 years now, we were kind of early adopters, if you will. And because we were early adopters and we went with the second company and we kind of changed our practices and built it into our culture, this stuff kind of runs in our culture in the background. We don't, it used to be the term, oh, I'm going to HR to be just cultured. It's no longer that, right? It's just you're coming in and this is just who we are. Our managers are very well trained in this. We've spent a lot of time and education on that. It's just part of our culture, which is great. The problem is that we want to be certified in this. And to be certified, the certifying body is not as prepared as we are. So we don't have it on display. And so they really want to see us put it on display. So that's kind of where we're going. Now, really quickly, I wanted to talk about how things come in. So, Alice, thank you earlier or Director Wong, thank you for mentioning the risk statement. A lot of times our folks don't recognize what the risks that they're trying to mitigate when they read our policies, so that definitely helps us. The reliability management team often gets their risks. Probably the most well-known is through our LDATIC system. Once we get a risk identified, it goes to a steering committee that then identifies, do we need to look into this further? Then it goes to the reliability management team for further review, and then sometimes it'll go through to a smaller committee, which will look at a risk that was identified and figure out how are we going to mitigate this risk. So that's just kind of a streamlined thing. I will say risks come in through all different avenues, right? It could be word of mouth, it could be through an event, it could be through a bad outcome, all types of different ways.
I will mention that RLDatix is our event reporting system, and so you can report anonymously, but it is on all of our intranet throughout the entire district, and it kind of consolidates in one area within our quality department. So then they get them. They do weed out a lot of behavioral issues that perhaps are less general risk, but then they do trend and kind of bring it forward.
All right, so there's two terms here that we're going to talk about. The first one is Just Culture, and the second one is going to be the reliability management team. So when we think of the DNV, who's going to be certifying us, I'm getting ahead of myself. There's a slide soon I'm going to explain why I'm separating these. But the term Just Culture has stuck. And Just Culture, in a nutshell, is how do we respond to the person in the bad event? How do we make sure that we treat them justly, that we're judging the system before we judge them, and we're creating a culture where people feel safe to speak up about errors, feel safe to speak up about bad outcomes. That's really what we want to do. And so we have embedded that into our culture and our policies by building redundancies, if you will, and roadblocks to make sure that we capture our biases, we do all the right things to make sure that that we don't treat the person wrongly, if you will, if that makes sense. So that's, in a nutshell, what just culture is. We could go on and on and on about it, but I want to reiterate, we've built it into our culture, and so we don't just have like a sign that says, okay, come in this room and you're going to be just cultured, right? That's important for you to know, because the certifying body, they really want to see that. They want to see, hey, you've been just cultured now, you've gone through the algorithm, and it's just kind of part of our culture.
I think another really large aspect of the collaborative just culture is that you're not just getting errors as they occur, it's really making sure that your net is wide enough that, like, as your staff feel comfortable enough that they see a potential for an error or a way that an opening that something can happen, that it gets reported, so that way we can preemptively move to fixing things.
Yeah. Before a bad outcome. All right, the next is the reliability management team. Again, we've had this team in place for a while now. This is a team of experts in reliability management, and they really look at, they're used in the just culture sequence, but then they're also looking at the risks to figure out how can we build new systems that are going to be very resilient in a human workforce and in a very interesting healthcare environment. It's not a simple thing. Oftentimes aviation is compared to healthcare when they talk about reliability, and it's just not the same, right? I mean, like the risks that aviation has, they can reduce those risks by just saying, hey, we're not going to fly today, right? It's very simple for them. We can't just say, that trauma, I don't think we should take that trauma today, right? Our employees can't do that. So it's a very, very complex system that we're dealing with. And so the reliability management team is tasked with building systems and looking for ways to build resilient systems in the complex industry that we have. So the DNV, it stands for Det Norsk Veritas. That is an organization just like JACO and the others, they're healthcare accreditation agencies. And they are the first organization to certify folks in high reliability. Now, this is a very new certification that we've been going for, and we likely are going to be surveyed in May. And they're going to certify us in two things. First, they're going to qualify us in just culture, and then they're going to qualify us in reliability management, in our reliability management team. Once those two things have been qualified, we have to prove ourselves for 2 years, and then after that 2-year mark, we can then become certified as a high reliability organization. As we know it right now, there are only 2 other hospitals that we know of that have been qualified in both of those. We're hopeful that we're going to be next. Now, there is a cost to this, and we did struggle with the cost, and we talked with Janet Van Gelder, our quality risk director, and she kind of talked us down a little bit to recognize that there's a lot of value working with an agency such as the DNV to make sure and check ourselves, to make sure we don't get complacent, make sure that we're still at the top of our game. And so that's why we decided to move forward with this, because we feel we're doing great in it, but to have an outside body come in and say, you guys are doing great, is going to be even better.
Alex, can you give us an example of how you prove yourself?
It's a lot of documentation.
Yeah.
It's mostly all documentation.
it's
So it's having our policies and practices all in place. So by having all of our risk statements and all of our policies, and having all of our practices as far as disciplinary and such, showing our collaborative just culture, having commitments from our leadership team saying that they're committed to just culture. It's a lot of background work and a lot of policy creation. For the reliability management team, it's about our minutes and our agendas and our chapter and kind of everything that we've done and showing our progress and what we're doing and how we're moving forward. And then for the actual team, when it goes to the HRO, then it's showing that like integrated, how well everything is actually functioning and all of your paperwork related to disciplinary actions, when there's any terminations, kind of how you handle the big things and how you handle the little things.
This is one of the areas I struggle in because I'm not great with documentation, I'll be honest. I have a great team for that, but I personally am not. But I will say, when we built this, started to build this 10 years ago, we really wanted it to just be our culture. And so we did integrate it into our culture. We have trained all of our management team with 6+ hours of training. We've done case reviews with them. We have we have become this new organization. Because of that, we've seen our disciplinary occurrences go way down, right? Things that used to come, even for a disciplinary hearing, they don't even come to us anymore. Because the managers on the front lines are seeing that, wow, we've got a bad system, and that's why this event occurred, right? And so, even still, every once in a while, we'll get something that comes through human resources, and maybe we're biased. This doesn't happen very often, but maybe, right? We're biased, and something gets through, and then we even still have a third unbiased person that comes through that's trained in these practices that can look at the entire situation before we discipline somebody and has the authority to say, this shouldn't be discipline. And we designed it this way. And so I'm telling you that because it's really difficult for us now to try to unpeel that onion to show a third party and say, see, this is who we are. They're having a really hard time seeing it. They don't see the great outcome that we've had from this so far. I mean, this is why we have great relations with our unions, right? This is why a lot of the things have happened. And so it is hard, and I'm so thankful to Jenny because she's the one that's really trying to show the DNV, like, this is who we are, and we've built this, and it's just really interesting. It's really interesting.
And it's a lot of alignment of our taxonomy to make sure that we're all saying the same things in the same way.
Yeah. They have certain vocabulary, and we've been using certain vocabulary for so long, so we're trying to adjust to theirs to make sure that when they come in, we're using their vocabulary. So I somewhat talked about this. Our last steps on this is we've got a couple more policies just to finalize, and the surveyor should be here. I think we said May, right? Around May to June.
Yeah.
And they'll come in and review us, and hopefully we'll be qualified as likely the third hospital that I know of.
As of this time.
Right, as of this time, which is pretty awesome.
They also interview a lot of our leadership.
I haven't told Harry that yet.
Oh. Sorry about that.
We'll talk about that tomorrow, Harry.
So do you get certified after the survey in May, or do you have to wait the 2 years?
Wait the 2 years.
So these are you have to qualify your entire facility as a collaborative just culture facility, and then you qualify as your team. And then once both of those aspects have been qualified for around 24 months, then with those qualifications, you can take to get certified as a collaborative high reliability organization.
So there are two that have gone through the whole process?
Nope, they have only done the first step.
Oh.
And they're the only two that have done both, it seems. And so it's online, it's virtually that they would come and look through all of our documentation. And they would be able to do it at the same time.
Yeah, and so what we're gonna have to do over the next 24 months is we're gonna have to document these things that we normally don't document because they're just done already, right? So we're gonna have to document when a manager says, oh, this was a human error rather than, or an at-risk behavior. We're gonna have to document that thought process that a manager has before bringing somebody to discipline, or document somebody came through discipline and through the reliability process, we determined that discipline shouldn't happen, right? So we have to document things like that, which is fine. We'll figure that out.
So do you know the areas that those other two hospitals are in? Are they in California?
Tampa.
Tampa General
And
and Palomar.
Palomar.
Pullman.
Yes, Pullman.
In Oregon, Washington.
Oh, so it's,
Washington.
Yeah.
so it's on the west coast.
Yes, and there are two hospitals that work with the same partners that we do, who worked with the DMV to create this.
Because didn't Just Culture start on the west coast? The gentleman was from Oregon that came and spoke.
I want to say Texas. It was a company called Outcome Ingenuity. The name
Oh,
is
no,
David
I was thinking about
Marks.
the gentleman who wrote the book.
Well, there's been a few books out there.
Paul Sage?
Oh, Paul Lesage wrote a different book, but he has, so David Marks and Scott Griffiths created Outcome Ingenuity, which created the Just Culture algorithm that everybody kind of flocked to. But the first thing that, when we would get this algorithm that we would do with our managers, Paul Lesage, he would say, okay, get out your Sharpies, and we're gonna change this, 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 and this, and this on this algorithm that you just spent $30 for, or $30 on. And then Paul Lesage and Scott Griffith, they started their own thing, which was Scott Griffith Collaborative, and he and Paul Lesage built up this company, which built a new algorithm, which changes as they learn. And we actually appreciate that, right? Like, as they learn new things, they change things. The old company didn't really want to change because they were making good money off of this thing, so they didn't change much of their algorithm. They thought it was good, and so we went with the new company that looked at systems before people, and we've been extremely happy with that theory and that way of doing things.
Okay.
Yeah. So with that, are there any other questions?
It seems to me as though there's also a synergy with our insurance company, with Beta.
There is.
And, you know, that all of this sort of, you know, seems to coalesce in.
100% correct. I will say that our insurance company does go with the other company, and we oftentimes when they come in, they are happy with what we're doing. Let me just stop there.
Well, they
They
give
are-
us a discount on the
They do.
insurance too, as a
They do.
result.
Yes,
So it's
they do.
Dollars and cents to us.
Yes, as the only hospital that achieves the 5 levels that they require.
Yeah.
And so, yes, it is part of it. We're doing the right things. Yes,
For the right reasons.
for the right reasons,
For the right
yes.
reasons, right.
Okay, any other questions on high reliability? But will you be hearing something after May or so?
Yes. Don't hold me to May. I'm hoping May, but full disclosure, it may end up in the new budget cycle because I didn't budget for the amount of money it's going to cost.
Okay. Any questions from our audience in regards to high reliability? Okay, then thank you so much for it. Thanks, Jenny. Then we'll move on to item 15, and this is Harry Weiss are going to present on some payment for assistant program increase.
Good evening, Chair and members of the Board of Directors. One of the things our team really values and cherishes as an employer here in this region, as we care about our patients, we focus on quality, but we're doing something very holistically to be a great employer in tough times and good times. And so a couple of years ago, starting in, I think, FY23, our board was kind enough to support us with a down payment program, just to really recognize how difficult it is to recruit and retain staff. And most of us know that we are a vital partner with the Truckee Tahoe Workforce Housing Agency, so we're one of 7 partners in that organization. And so we're just really happy to share with you that that program is able to reduce rents through a variety of strong programs to below newspaper prices for people that are just looking to rent and work for us or other employers in the region. But then we also said based on the surveys of our team members, we need a down payment assistance program. And, you know, if we were to go out and buy one home and then try to find somebody to rent it, there's just a very large expenditure of dollars for one home. And we can probably help about 8 families choose their own home for what we might spend, that they would own, for what we might spend to buy one and rent it out. And so we're just really happy to share that we're dealing with our 8th family right now. And at the core of the reason it's brought forward, your board has kindly given me $900,000 limit per fiscal year, and I'm requesting an additional $200,000 this year to try to get us through to June 30th so that I can help an 8th family. I need a little bit more headroom above the 900,000. And by context, we spent about $388,000 in fiscal year 23. Right now, I know of about $960,000 that we might spend in fiscal year 24. I'm asking for 200 additional, so that would give me about $140,000 leeway, you know, in case something else. It may not be enough, but I'd really like to close the loop on the 8th family being able to buy a home. So staff's request is that you authorize the CEO to spend up to $1.1 million in fiscal year 24 for down payment assistance.
So, Harry, down payment assistance, it's a loan to these individuals that's highly secured by the property itself.
It absolutely is.
Okay. And it's a low rate of interest?
That is correct.
Okay.
Okay.
Just another question. That, they have to be a hospital employee of some type to get this assistance?
That is correct. One of the beauties of our program is being a large employer in the area. In one of the, I think the previous 7, one worked for us, another worked for fire district, another situation, an employee worked for us, and the other one worked for the school district. And this one is, just touches us, but the program has been viewed so positively. One of our other 7 partners, the airport district, has also replicated our program, and they're starting it for their company as well.
Great.
So we really want to help small to large businesses or encourage them to have new processes, but again, this is just for our employees.
And Harry, how are those employees, I mean, if there's more that are requesting, how do you decide which ones get it?
They come forward and they work through our workforce housing agency. We screen it from HR and other personnel to make sure the team members are in good standing. And then if we get the green light, then the final decision is mine. And so we do have limited funds. So,
Right.
But so far, I don't think I've had to say no to any requests.
And can they get funding, further funding through the workforce housing? Because they have several options you can get money from to help with purchasing a house.
It does take a well-informed lender to serve in a first trust deed role, and then you have the employee putting money in, and then we're in a second trust deed role. We have not found the situation where we could stack money in from other sources out there that has not fit any of our, because of income levels or other things.
Right.
Is there any requirement to repay the loan if they leave the hospital employment?
Yeah, if they leave or refinance and so forth, there are repayment conditions that can happen, sell or leave. Or
Okay.
Do these people that we've helped in the past, do they represent all different pay stratas?
They do, all different levels. And it's also a tool for those that are most hard to find as well, but it gives me a great deal of satisfaction when it touches, the close to the very front line of our team, and I'm happy to say we've touched frontline team members too. It's a super thrill to be able to do that.
Okay. Any comments from our audience? If not, can I have a motion? I'm sorry, I lost it. Can I have a motion to increase the spending limit in fiscal year 2024 to $1,100,000, which is an increase of $200,000 for housing assistance program?
I will move approval.
Could I have a second, please?
Second?
Okay, so it's been moved and seconded to increase by $200,000 our payment assistance for fiscal year 2024. All in favor?
Aye.
Aye.
All opposed?
Harry, sometime in the near future, could we get a report on the workforce housing program?
We can. Yeah.
And what we're contributing to that and what we're receiving,
Right.
our employees are receiving in return.
Okay. And we have a new,
We have a new executive director.
yeah,
now.
so we'll get to hear her then. Okay. All right. So that is the end of our agenda for today. We didn't pull any items from the calendar, so we don't have to go to that. Any board committee reports? Governance met at the beginning of March. We went over the board self-assessment, and I think all of you should have gotten the analysis that the governance committee sent out. And next month, we'll be talking more about the goals from those opportunities that came out in our board self-assessment. We'll also be looking at an educational plan for 2024. At our meeting, we went over the revisions that were needed in policies for 2024. We did look to make sure there were risk statements on the board policies. And then today we approved 3 of them under our consent calendar. And that's what governance did this month. Does any board member have any reports or closing comments they want to make?
Yeah, I do. One of the responsibilities of the board is oversight. It's not enough for the board to simply, for instance, pass an annual budget. It's also our responsibility to ensure that periodically that we're meeting the budget. So oversight's an important consideration for this board. We all hear from time to time about significant emergencies that occur across the nation. In the aftermath, there's always something to be learned. Was it done right? What could be done better? Does Uvalde come to mind? Terrible tragedy for that. And as I recall, there was a school shooting in Florida also, terrible outcome and not handled well. At our winter injury symposium a year ago, we had a report from an individual who was part of the emergency disaster recovery team after that significant shooting. And he had a lot of comments, if you remember, Harry, about what they felt they did right, what they did wrong. On page 138 of our agenda, it states the Emergency Management Committee, EMC, will test the emergency operations plan at least twice per year, either in response to an emergency or a planned exercise. I don't know if the rest of the board feels like I do, but I would like to hear a report about that test and what did we do on the test? Is it well accepted by all employees? Do they really get into it? And or do you feel like you walk away from it with having learned something? So if the rest of you agree, I would like to hear something about our emergency management test and how well it came off. And so, Louis, is that something that is in your area of
absolutely happy to report on it on our report.
Yeah.
And we can put that, we have a rolling, we don't necessarily have to do it now. I think.
No.
Yeah. We have a rolling list of topics.
Absolutely.
Okay, then we can put it on one of our future agendas, Louis. Okay.
Okay.
Any other comments or reports? Okay, if not, then this meeting's adjourned.
All right.